Good morning, everyone. I am Professor Zavos, and I'm speaking to you from the Andrology Institute of America in Lexington, Kentucky, and I salute you this morning. I'm going to talk to you today about the facts and future prospects in andrology. I want you to generate some thoughts, and maybe we'll discuss them a bit later. And infertility, as we all know, is a pandemic. It's been that way for a long time. Anywhere I go, all over the world, people suffer from infertility. And obviously, I do see different schemes of infertility, sometimes a little bit more emphasized of one kind or another. But more of the story is that both the male and female bring to the table difficulties and problems that we intend to solve and get results by correcting both the male and female. I happen to be spending a lot of time, some like 43 years now, concentrating on the male, because at the time that I entered this market, I discovered that not very many people believe that the male could be involved in the couple's infertility difficulties. This particular scheme shows that 27% there's incidence of male factor infertility in the couple's difficulty to establish a pregnancy. However, I've seen as much as 40%. Therefore, this number is obviously significant. And what we obviously aim to do here is to correct the 27% or 40% or whatever it might be. We just have to develop the criteria for the evaluation of the difficulties and the modalities via which we can treat the male. We know a lot about the female. And of course, most infertility specialists today are female infertility specialists. They graduated from MD degrees, OBGYN subspecialty, REI subspecialty, but they're all concentrating on the female aspect of reproductive medicine, and they leave the male to us, and that's fine with me. Now, if we know about the female, what do we know about him? Well, the causes of infertility in the male are quite numerous. And unless we know what could be the causes of infertility in the male, we'll never be able to correct them. So it's the etiology and the treatment modalities that go hand in hand in order for us to be able to treat infertility. The evaluation of the male patient is very, very important. The detailed history is obviously of immense importance, because we need to know where he has been and where we need to take him in order for us to be able to make the trip successful. Now, when it comes to physical examination, that's another story, and so is the laboratory testing. The history, as I said, is very important. If the male is cryptorchid, or the male it has orchitis or had orchitis at age 5 because of the mumps, and it became azoospermic, we know exactly what the etiology is and how far we can take the male in order for us to help him out with his difficulties. So history is very important, and we need to sit down with the patient and analytically find out what might be in the history that can give us a clue of what we need to go after. Now, the physical examination is another issue that really kept me busy over the last 40 years. Most of the time when the couple shows up at your clinic, you say, well, I don't know what to do with the male. I have a urologist friend of mine. I'm going to send him across the street or across the hall, and he can do the urological examination and then tell me what might be the difficulty, if there is any. First of all, the urologist is a specialist that specializes in the urological system. And because the reproductive system associates with the urological system, that doesn't make him a male infertility expert. He's not an andrologist. Therefore, he gives me a urological examination, finds out, oh yeah, there's a couple of things in the scrotum. I can feel them, how big they are and how active they are, how stressed they are, how hard they are, how this, that. Is the epididymis there or not? We don't know. But then, of course, I think he's okay. We kick the tires, we send him back. That's not good enough. The male examination has to be done by an expert that knows the male anatomy extremely well, and he has done this for living. Therefore, testicular damage, epididymal irregularities, penile abnormalities, all those things need to be evaluated in order to make sure that the male has what it takes and deliver the goods in order for us to get results when we put the couple together. Testing, laboratory testing, obviously, is another issue. Sometimes we do the laboratory testing first, and then we go to other modalities. And then, of course, I'm not going to talk about hormonal evaluation today, but let's just assume that you will find an endocrinologist that would do the endocrine workup for the male, just you do endocrine workup for the female. But let's concentrate on the routine semen analysis. The analysis is a very simple thing to do if you know what you're doing. And it can be obviously indicative and give us directions as to where we need to go in order to correct this male and get it to procreate. So when we look at the routine semen analysis, we look at the count, the sperm motility, progressive motility. We look at the pattern of motility. We look at a number of different aspects of the seminal plasma, the pH. Are they white blood cells? Are they red blood cells? Is there agglutination? Is there UFOs, as we call them, unidentified floating objects, debris in general? The semen should be clear of all those things. And when we see all this disturbance, we obviously ring the bell and say, there's a problem here. We need to identify it and correct it properly. The routine semen analysis include also sperm morphology. If I was to take one parameter that gives us the most problems when we evaluate the male as far as RSA is concerned, is morphology. People don't really get an understanding of what a normal sperm is, and because they don't, then they do not know how to call an abnormal sperm. And therefore, abnormalities are, morphological abnormalities are deviations from the normal sperm morphology as we see it. And then, of course, the pattern of sperm morphology can give us a kind of ideology as to what could be happening. Why are the sperm cells crooked neck? Why are the sperm cells round-headed or having a diploflagellate or having elongated heads or whatever? Could be heat stress. It could be chemical stress. It could be all kinds of things. And therefore, the morphology is very negative. And when you tell somebody you have less than 1% normal morphology, and I think I'm going to do an IUI, and I saw a patient like this last week when his doctor told him that we can be successful with less than 0.5% normal morphology to get the wife pregnant, the guy must be believing in miracles. Therefore, there isn't such a thing as 0.5% normal morphology. And then there's normal motility and normal progressive motility and all that. All those things go together. When there's an error at the assembly line, the error spreads around to all of that, all of the things, all the parameters, the sperm count, the sperm quality, the sperm motility, the progressive motility, morphology, and all those things. And therefore, there's somewhat of a synergistic effect on the sperm because of the inability of the testes to produce normal sperm in general. Agglutination is something that we don't spend too much time with, but it is a very significant thing. Sometimes it takes about 5 to 10 minutes the sperm to settle down in the seminal plasma before we can see the agglutination pattern, because it probably the origination of the agglutinins and the stickiness of the cells doesn't appear until then, and therefore we need to pay attention to that as well. Now, one aspect that I spoke about a year ago in India was the DNA fragmentation aspect. We really have ignored a great deal the measurements of the DNA integrity in a sperm. And I think that there is technology today that can give you very fast readings of the DNA fragmentation by doing that in the laboratory as a routine thing, along with the rest of the analysis results or analysis parameters that we consider. And the DNA fragmentation is very predictive of the male's ability not only to fertilize, but also enable the female to maintain the pregnancy. It's been estimated that a normal DNA fragmentation should be ranging between 3 to 8%. The abnormals obviously elevate significantly, and when they go beyond 30%, we see a significant reduction in fertility potential and a greater risk of miscarriages in the female during the pregnancy. And therefore, we need to pay attention to that when it comes to identifying such patterns in the couple's inability to carry the pregnancy. The parameters need to be put side by side and evaluated as such, and look at the whole profile, the total picture, and say, well, we have oligospermia here, we have teratospermia, we have actinospermia, we have globospermia, and all those kinds of things. And then we put it all together and say, I think this male is somewhat problematic because of his environment that he works in, the way he grew up, the way he takes care of himself right now, he suffered of a disease or something. And then we make obviously some conclusions as to the direction where we want to take the male and have it corrected. Now, let's talk a little bit about ARTs. We begin with the IVF because very simply IVF came first in 1978 with the birth of Louise Brown and Robert F. Edwards in England, and Steptoe, of course, God bless him. God bless both of them, Edwards and Steptoe. IVF can solve problems both for the male and the female, but let's talk about the male right now. We can obviously do an awful lot of things in a petri dish much better than and enable us to fool Mother Nature a little bit better. We can use ICSI. We can also go into the testes and aspirate sperm or remove sperm via surgical techniques and put them in the dish and identify them, isolate them, and do ICSI. We have introduced technologies such as the round spermatid injection, ROSI, in 1995, 96, 98. We published several papers on ROSI. And then, of course, the last resort is sperm and oocyte donation, which, of course, in various cultures and religious believes people don't go that way, and we respect that very much so. But obviously, that's the last resort that we can discuss things with the patient if need to. IVF, as the term implies, is fertilization in vitro in a petri dish. After we recover the oocytes and the sperm, we unite them together, we get fertilization, we transfer embryos, and we get a pregnancy, and it gives us about a 35% live birth per transfer. ICSI is when we introduce the sperm directly into the ooplasmic region of the cell, the egg that is, and then by doing so, we cause fertilization. And again, the success rate is very similar to IVF, except that in this particular case, we introduce the sperm directly into the ooplasm of the oocyte. Now, we obviously need to realize here that the difference between culturing eggs and sperm in a petri dish and doing ICSI is a lot of fooling going on of Mother Nature. And there are also limits how far we can go. When I lecture on fertilization and the various aspects of what the sperm has to undergo to fertilize an egg, and what the egg needs to undergo to allow that sperm to penetrate and fertilize that egg, is quite an accomplishment. Versus the direct injection of the egg into the sperm ooplasm, which can yield the same results, fertilization. And then, of course, over the years, and for us that evolved in the era where we used to incubate sperm and egg together and then wait 24 hours to see evidence of fertilization. Today, ICSI is another issue. Sitting side by side with Robert Edwards over the years, he's been a friend of mine from '79 since his passing. And God bless you, Robert Edwards. You've done so wonderfully well for me and for the rest of the world, and I thank you for that. He was always urging me and asking me a question. I am always concerned about this ICSI business. Do we know what we're introducing into the oocyte when we directly inject the sperm and what comes with it, the fluids and all the other disturbance and chemicals that we put? as we isolate the sperm and inject it into the ooplasm. That Panagiotis immensely bothers me a great deal, and time is going to tell. Well, I think time is telling us a lot. I think as we began to do ICSI, and today we pay a lot of attention, the volumes that we introduce, the chemicals we introduce into the ooplasm, and therefore I think that we can tell Bob Edwards to rest in peace. All is well. Now, we do testicular sperm extraction via removing portion of the testicle. We dissect it, and then we remove and isolate sperm, and we inject it via ICSI, and we can get somewhat good results, assuming that we can get testicular sperm to serve its purpose well. We can also remove sperm via testicular aspiration, TESA, and then that is another issue there. I prefer TESA than TESA because I'm capable of going in and aspirating and finding out the soft spots and do the mapping on the sperm on the testicle and identify where there's a good chance that I can find sperm when I go in with a needle and I come out. The round spermatid injection, we introduced it back in the late 1990s. We published several papers on that. We're somewhat successful, but we think that we have much better directions today with Rosie, and time is going to tell how far we can go with that as well. However, we tried that, and I think that is another issue that we should be working on. In 1995, I introduced a technology known as male factor pack. It's a non-spermicidal condom that allows the male to produce at intercourse versus masturbation. And I showed very clearly that when the male produces at intercourse, produces a superior specimen that can give us more volume, more sperm, better sperm, and therefore we can take a male that is somewhat subfertile into the fertile zone by allowing him to produce a specimen at intercourse versus masturbation. And this has been a remarkable development, and it's used now almost throughout the world. Recently, we've done the production or the birth of the first stem cell baby in Pakistan at the Andrology Institute of America, where we take stem cells from the male, we incubate them, we obviously prepare them properly, and then we perfuse the testicle with stem cells, allow the male to go through 1 or 2 spermatogenic cycles. We test them, we find out sperm, and then we proceed accordingly. There's a man here that came to us as azoospermic and went home and got his wife pregnant, and he's holding his son with so much pride. Husband and wife, the child, and Dr. Sajida in the middle at the Andrology Institute of America, at the Andrology Institute of Pakistan in Lahore, Pakistan. This has been a very remarkable development. We are not very successful on that as yet, but we're getting there slowly, slowly. Then, of course, we tried human cloning. We still believe that human cloning could be an ideal way of treating infertility for those people that have really no other option. They exhausted all other options. And when we created the first clone embryo, we submitted the manuscript to Robert Edwards, and in 15 days, he included it in the edition that came out. And he was gracious enough to publish the paper right away and put the first clone embryo in the history of the world on the cover of the RBM Online. And then he was kind enough to autograph one of those manuscripts, of those journals, and send it to me with the expression, "With all best wishes, Robert Edwards." And I already submitted that manuscript, that journal, to the Smithsonian Institute as a collection for things to come in the cloning world. We also were successful in creating more embryos, and we transferred them in 5 women, and we published the work in Archives of Andrology. And again, this is work that is continuing. Therefore, I need for you to understand that there are problems that are arising every day, and we are in the business of developing new modalities and new ways of treating male infertility as we go along and as we see different problems arising. Now, I'd like for you to give me a few moments to talk to you a little bit about recent events as far as COVID is concerned. We submitted this manuscript about 3 weeks ago, and it was accepted, and the manuscript is in press, and it will be appearing in a journal, a British journal, next month, the July issue. This was work that was done jointly between us and the Andrology Institute of Pakistan, myself, Theodora Maria Zavos, a visiting scholar, and Dr. Sajida Shanawaz from the Andrology Institute of Pakistan in Lahore, Pakistan. What we set out to do in this study was to investigate males that were infected with COVID and males that were not infected with COVID. And we obviously put them side by side. We equalized and designed the experiment in such a nice way so we can balance the two populations, be able to be a control of the other. And the investigation was to look at the traditional seminal parameters of infected versus non-infected, DNA fragmentation, and reactive oxygen species by the sperm, or the disruption of antioxidant defense systems in the male reproductive tract of those patients. The data is there, and it shows that COVID is already been identified and located in the testes of a COVID-infected male. A group in Miami already done this work, showing here via electron microscopy that the COVID virus that you see here and also here is present in the testicles. And the question that I wanted to ask is, what do they do there? Why are they there? I'm sure that this virus is not going to get into the testes and settle down and do nothing. I'm sure he's going to be as destructive as he is when he gets into the lungs and into the other systems of the body and causes the kinds of side effects that it does. Therefore, in table 1, we're showing the results of the various spermatogenics parameters that we assessed. You see here that the two groups, uninfected and infected, equal number of patients. The ages are shown here, 41.2 and 40.5. The infected group was that we had semen parameters before the infection, and then we waited 110 days later, and we called them up to come in after we found out they were infected, and gave us another specimen. And then, of course, it was easy for us to find out patients of this age group. And then at 0 time and 96 days later, they gave us a second specimen. And you'll see here that the volume did not change. The count went down when we compare the before and after infection. The total count went down as well. The motility dropped significantly. The grade was reduced, and the normal morphology was significantly reduced as well. This is strict morphology as we see it here, okay? Now, when we consider the DNA fragmentation data and the ROS data, we see here some very dramatic developments. In the two groups, we see that 83 and 91 before and after for specimen 1 and 2, where in the infected population, it went from 10.3 to 33.7, a threefold increase in the DNA fragmentation. And then from here, we see that the ROS, it increased 100-fold from 0.32 to 34.32. Now, what we see here, obviously, what is of significance is that the DNA fragmentation went from a normal level to the level where we obviously review and already indicated that can cause significant effects on fertilization and subsequent onset of pregnancy and maintenance of the pregnancy during the gestational period without any spontaneous termination of the pregnancy. And those developments are of immense importance. So going further here, we can conclude that the data clearly depicts significant effects on almost all of these parameters. The DNA fragmentation went from normal to abnormal. And then, of course, it shows that the DNA went into the level where it can cause significant effects on the onset of pregnancy and maintenance of the pregnancy. And then, of course, again, the ROS kicked in. And then in line with the DNA fragmentation, the ROS is an indication that we have some trauma taking place in the testicles of the male that is obviously can cause some very significant disruptive phenomena that could interfere with the ability of the male to procreate. So where do we go from here? The findings in the current study are so important that are telling us now that SARS-CoV-2 is just not only a respiratory disease or a vascular disease, but it could be also a reproductive disease. Although none of us are dying if the CoV-2 enters our testes, for those people that aim to reproduce, it could really limit their ability to procreate. And therefore, for the future, I should say that the male reproductive specialist not only should be asking the male, have you had mumps? Or have you had any injury? Or anything else that could really predict or tell us a little bit about your inability to impregnate your wife? We can say that, have you had COVID infection recently? How significant was it? How serious was it? Did you get hospitalized? Did it cause you any complications? And therefore, we need to be paying attention to that. And possibly as we go along and we learn more about this, we may just learn that the COVID infection in the testicle is something that is temporary and goes away, or is something that is chronic, that once it damages the testicles, they may never recover. We do not know that. Time is going to tell. And it's been such a great privilege to speak with you today. And I thank you very much. Have a great time. Thank you.